Should I share my screen?
Hey everybody, welcome to the Neuroblastoma Parent Global Symposium. My name is Gregory Sizikov, and I'm honored to be moderating this session. This is on Naxitamab human hu3F8 studies, which is being delivered by Dr. Jaume Mora. He's a scientific director at the Pediatric Cancer Center at Barcelona. In case this is your first session during today, there is a Q&A button at the bottom of your Zoom screen. Feel free to submit questions as we go, and hopefully Dr. Mora will be able to address them at the end of his talk. So without further ado, over to you, Dr. Mora.
Thank you, Gregory, and thanks the organizers for this extraordinary opportunity to address such a global audience of parents and associations supporting the neuroblastoma research worldwide. It is, as I said, my pleasure to share with you the experience of our group for the last several years and the work that we've done together with Wymb in order to make this anti-GD2 immunotherapy more broadly available to more and more patients worldwide. So as everybody knows, and what has been very well summarized in previous talks today, we know high-risk neuroblastoma is a very difficult to cure disease, and even nowadays, and its overall management can be summarized in this slide. Basically, there is an induction phase where the goal is to eradicate all the detectable disease possible. And this is usually done by chemotherapy and surgery, after which there is an evaluation whereby most importantly, achieving a complete remission, it is so desirable for the future of the outcome of the patient. And then it comes a consolidation phase where the goal is to basically eradicate what we call the minimal residual disease, and basically to drop down or to decrease as much as possible the chances of relapse. And this is basically done by radiation in the primary tumor sites where the bulky disease was in the beginning, as well as anti-GD2 immunotherapy, which has already been shown to be an efficacious way of decreasing the chances of relapsing for these patients. So first, I want also to pay a special tribute to my mentor, Dr. Naikung Chang in New York Memorial Sloan Kettering, who was one of the leaders and pioneers in the development of anti-GD2 anti-immunotherapy for high-risk neuroblastoma, and that has made the major discoveries in this field. He was actually one of the very first who, in 1985, discovered the GD2, the ganglioside in the neuroblastoma cell wall, as one of the most important glycolipids that could differentiate the neuroblastoma cells from other tumor types. Although he also described that this ganglioside was expressed in other tumor types like osteosarcoma, and described several antibodies that had then come up to a significant advances in the immunotherapy strategies. Well, he described the ganglioside, and the GD2 has been amazingly turned into a very significant and important target for antibodies. And this is also an amazing story in itself, because this is a glycolipid, and this is usually glycolipids or glucids and fatty acids are not that much immunogenic. So that was sort of a good chance in the path towards immunotherapy for neuroblastoma. That's a long time ago. But then also he discovered that the monoclonal antibodies against these GD2 membrane antigens were really weak to kill the tumor cell. It did enhance the reaction and use what we call the effector cells, which are basically the cells that are in the bloodstream of the children with neuroblastoma. And these cells are actually recognizing the antigen antibody reaction, and actually are those who kill the neuroblastoma cells. And this is what it's called antibody-dependent cytotoxicity. Well, certainly neuroblastoma occurs mostly in children less than 5-year-olds or very young kids, where their immune system is basically what we call based on the innate immune system, which is basically made of macrophages and neutrophils, dendritic cells, not so much so from what it's based on the adaptive immunity, which is based on the lymphocyte. So we cannot count much on the lymphocyte to do the job. So for the longest time, a New York Memorial Group has made their sequential studies showing that based on the same backbone of treatment with the same chemotherapy, same radiations and surgery, adding on the antibody alone, they were able to have long-term cure of approximately 40% of the cases at the time when almost none of the patients were surviving. Just adding on the GM-CSF, the immune stimulant for the granulocyte and the macrophages, were given intravenous, they increased the survival rates for those patients as well. But look at amazingly, when they switch the exactly same backbone of treatment from IV to subcutaneous, meaning more prolonged immune stimulation of the immune system, the survival rates grew significantly, with the cure rates that went past 60%. That is for patients achieving first complete remission or very good partial remission with the induction phase. That was really an amazing story in itself, showing how immunotherapy, anti-GD2 immunotherapy, would make a difference. But not until 2010, when the COG made this landmark study and published the results with this randomized study showing for children who had received standard induction treatment followed by autologous bone marrow transplant and incomplete remission, then is randomized to receive anti-GD2 immunotherapy, the dinutuximab antibody plus GM plus interleukin-2. They showed a significant difference in the chances of decreasing relapse. 63% of children with immunotherapy would be free of relapse, whereas 42% those who did not receive immunotherapy did not relapse. But most importantly, the overall survival of children in this randomized study was also significantly higher for those receiving immunotherapy. That was really the final proof that made this discovery, which had taken more than 30 years from phase 1 initial clinical trial in 1995 all the way to 2010 for that publication, and more than 2,000 high-risk neuroblastoma patients treated in the United States, mostly over 20 years, to get to the final approval by the authorities in 2015 in the US, and followed by the European authorities approval. And that's for unituxin, now the dinutuximab. And then dinutuximab beta came later. The story of dinutuximab is also well known, and the trials have shown the sustained improvement in event-free survival 5 years later. And more importantly, in 2014, they also showed that the improvement in overall survival, meaning patients, whether patients were alive or dead, was still significant much later than the publication in 2010. So this is certainly a landmark in the neuroblastoma studies. If listed here are all the randomized studies that are considered the gold standard for the knowledge and the clinical medicine advancement. So all the randomized studies have shown for high dose in induction chemotherapy to improve event-free survival, meaning whether the relapse rate changed significantly. And yes, higher dose induction improved event-free survival, but significantly, they did not change overall survival. The same for autologous stem cell transplant, which is, I know, a very controversial subject. But this, when we scientists, we physicians, we talk about improvement of survival, we are very used to use only the event-free survival statistics, but certainly has not improved overall survival, meaning those patients with transplant would relapse later, but they did not improve at the end, 7 years later, the increased number, they did not cause an increased number of survivors. And this is something very important, and that's going to be a major subject in my talk all along. So at the end, only the immunotherapy, anti-G2 immunotherapy has shown to improve the overall survival of these kids, although event-free survival might not be increased significantly. And this is a very important subject in this story. So this is a summary of all the learnings of the first 20 years of studies, whereby the antigen-antibody reaction activates the complement in the bloodstream, actually inducing the death of the neuroblastoma cell, as well as enhancing what we call the effector cells. We mentioned macrophages, granulocytes, NK cells, dendritic cells, all these innate immune effector cells that are actually those who kill the neuroblastoma cells. Well, what the GM-CSF, because outside of the US is not available, has not been tested formally, but the experience from all the groups in the United States show clearly significant improvements when GM-CSF is being used, added to the antibody. And I already mentioned the effect of adding actually subcutaneous GM-CSF into the survival rates in the Memorial Sloan Kettering experience. So all those initial studies were performed in the minimal residual disease stage, where no evidence of disease was present in those patients. What about refractory patients with neuroblastoma persisting in the bone or bone marrow compartment? Well, the MSK group, again, was the first to test their initial hu3F8 antibody plus the GM-CSF in those patients as well, showing again the same result. The overall survival for these patients increased significantly, although the event-free survival, progression-free survival might not have changed, meaning patients might relapse, but they don't die of the disease as much as those in the past. So what about patients who had relapsed and that achieved a second complete remission? Well, those patients were actually also very rare at that time, but the Memorial Group also showed that adding the antibody for those patients as well increased and actually induced long-term survivors cure rates at 10 years after having relapsed. And this is a very important subject, very important learning for families and patients. Well, in fact, there is hope after relapse currently. So this is what I summarized for 25 years of research of what we call now the first generation of antibodies or chimeric antibodies. The antibody alone efficacy is really weak. We certainly need the GM-CSF and immune stimulants to make it even stronger. The chimeric antibodies generate also blocking antibodies and other secondary antibodies, which suggest the release of an anti-idiotypic response, which might also be the reason why some of these patients who actually get cured might have a long-term protection from an anti-vaccination effect, which we will talk at the end of the session. The clinical activity of those antibodies was shown to be much more important in the osteomedullary compartment, meaning against bone and bone marrow disease. And that has been reproduced by all the antibodies, the anti-GD2 antibodies. Overall survival has significantly improved, but not so much the event-free survival, meaning patients still recur and relapse, but they don't die as much as before. And also something that is really cruel for families and patients worldwide, the cost of these antibodies is really high. $50,000 or euros per cycle times 5 cycles makes a huge amount of money that is not affordable for majority of children in the world. But not only that, but outside of the US and Western Europe, certainly, availability of these antibodies is still very limited. So this has not really solved the problem of a therapy strategy that has made a major impact. So this is basically for what I like to show as the Concord, which was the pearl of the airway engineering in the beginning, but nowadays nobody would ever try to fly or dare to fly with such an airplane, because we have a second generation of immune strategies, or anti-GD2 immune strategies, and these are based on more potent antibodies and combinations. So again, Dr. Chang in 2010, 2011 asked for the help of the families once again in order to make a fully humanized antibody, genetically engineered, not from the early 1980s, where he discovered the murine-derived antibodies and made the chimeric. But this is an antibody that has been made with all the tools that we have now available for bioengineering. And in 2012, they published the significant finding of a very potent antibody that in 2014, again, thanks to the initiative of the parents, was licensed to Wymb to make it clinically available worldwide. And as of this month, we are expecting the FDA to approve Naxitamab, or humanized 3F8, that it's going to be called in the US, the Nielza. This is in itself a very short lack of time for a development that in the second generation of antibody has taken less than 10 years, whereas the first generation of antibodies took more than 25 years. So this is to congratulate all the group from NSK in leading this novel potent antibody into the clinic. So again, what is the difference of Naxitamab compared to the chimeric antibodies? All these antibodies have special features with efficacy mechanisms that can be tested in the laboratory for complement-mediated cytotoxicity or antibody-mediated cytotoxicity through polymorphonucleares or NK cells. And that can be measured actually. And you can see that Naxitamab is several times more potent than the chimeric antibodies. But not only that, these antibodies also have a very short half-life as compared to the dinutuximab family of antibodies, which also impact in the way we administer these antibodies. So what can we do here in Barcelona for children with high-risk neuroblastoma, together with Wymb to make all these children, to make high-risk neuroblastoma more available to make available Naxitamab to more children in the world. So this is the list of trials and activity and treatments that are available. Humanized 3F8 with GM-CSF through the clinical trial 201, that is for refractory neuroblastoma in the bone and bone marrow compartment only. This is an active multi-institutional trial. We also have a compassionate use for patients in complete remission that I'm going to show you some of the results. It is to open the 202 trial very soon for patients in complete remission through the Wymb company, and the GM-CSF being developed by Wymb as well might become available very soon. So we mentioned patients high-risk neuroblastoma getting the induction chemotherapy and surgery, and then being evaluated. Patients in complete remission at that time, they will be eligible for the Wymb 202 trial, soon to be open, or compassionate use in our center as a consolidation phase. If patients were in partial remission, meaning having refractory disease in the bone or bone marrow compartment only, they will be eligible for the Wymb 201 trial. Of course, patients in progressive disease, they would have to go on to other strategies before being eligible for any more treatments with anti-GD2 antibodies. Well, this is the schema of Naxitamab plus GM-CSF, which is being delivered outpatient. And this is something that is a major difference in the quality of life of families and patients as compared to the dinutuximab family of antibodies. So a backbone of 10 days of GM-CSF administered subcutaneously at home, and 3 doses of high dose, 3 doses within the second week of high dose antibody Naxitamab. So for first complete remission patients at our center, patients with no evidence of disease in 4 bone marrow aspirates, MIBG and PET, and whole body MRI, all completely negative. We've treated 49 patients, 34 in first complete remission, 15 in second complete remission. Out of these 49 patients, 13 have not been able to complete treatment, either because of toxicity of the therapy that we're not able to sustain, and 9 of them having an early relapse. Remember, those patients were in complete remission. Relevant toxicities have been described with manageable pain in the outpatient setting and hypertension as a unique, quite unique feature of Naxitamab in these patients. Well, what is our survival rate? Well, we've been able to reproduce what the Memorial Group was already showed in before. A 2-year overall survival of 86% for the whole group, better for the first complete remission as compared to the second complete remission, and an event-free survival of 72%. Again, much better for the first complete remission as compared to the second complete remission, meaning that patients with a history of prior relapse have a much higher chance of recurring again. So I know this is a very controversial issue. What about bone marrow transplant in this setting? Well, for the last 6 years in our center, we've been treating patients with anti-GD2 antibodies, Naxitamab, and prior with dinutuximab and the COGD strategy for antibodies, regardless of whether the patient had received prior transplant or not. So we've been able to recruit a large group of patients without bone marrow transplant. And we just recently published our results, which actually reproduce what the Memorial Sloan Kettering Group had already published in 2015. Well, basically that having received autologous stem cell transplant prior to antibody consolidation did not make any difference in our experience as compared to those patients who had received the transplant. So overall survival is exactly the same in this cohort as it is the event-free survival. So what about the comparison, which is really the numbers in our experience, as I mentioned, for first complete remission patients? Well, I showed you the numbers from the COG trial, 84% overall survival at 2 years. Well, we have reproduced this 2-year overall survival of 86% without transplant and using Naxitamab in our group. And event-free survival also 72% at 2 years, very similarly without transplant. So in our experience, having received transplant did not make any survival benefit. So for first CR patients, we can summarize. In our experience with Naxitamab, there's no need of bone marrow transplant for consolidation. Treatment is given in 30 minutes in the outpatient setting with significant improvements in the quality of life of patients and families. The overall need for opioids is 7 times less for patients that in same patient had received in the past dinutuximab in our group, and then received Naxitamab. For the same patient, we had used 7 times less amount of opioids for pain management. Significant toxicities for dinutuximab. We had reported transverse myelitis, not seen for Naxitamab, although for Naxitamab we have had an increased frequency of hypertension, as I mentioned. Well, price and availability is in the hands of Wymb is still pending, and we like to show a significant difference to make the availability of this antibody worldwide for most patients. So what about refractory neuroblastoma? I said primary refractory neuroblastoma is the persistence of the disease after first-line treatment, meaning induction therapy. Salvage regimens have shown an average of 30% response rate, not cure rates. And even MIBG therapy has shown as well in 25 studies about 30% of response rates. Very poor outcomes in this setting. So what about using for this persistent detectable disease in the osteomedullary compartment anti-GD2 immunotherapy, Naxitamab? Well, this is the case I'm showing you. In October 2018, this patient came after receiving chemotherapy and surgery in his local center. So as you can see, MIBG with a large disease in the skeleton, basically with a Curie score of 18. So the patient received 2 cycles of Naxitamab and GM-CSF within the 201 trial, as I mentioned. With 2 cycles, the Curie score dropped to 6. So significant response, partial response though, but significant only with antibody in the bone, the refractory bone disease. And these are the MIBG spots still remaining in this patient after 2 cycles. Well, after 5 cycles, this patient achieved a Curie score of 0. This is quite an amazing response, and we've seen this in a significant large number. And the results of this, preliminary results of this 201 trial were reported recently at the SIO 2020 a month ago, with 71%, 10 out of the 14 in the refractory setting achieving complete responses. So this is really a very powerful tool to get these patients into a complete remission. This is a significant case. As you can see, this patient was diagnosed of high-risk neuroblastoma in 2014 and treated with standard management with no autologous stem cell transplant, but with dinutuximab GN and interleukin-2, according to the COG trial that we had at that time available in our center. She achieved first complete remission in 2015. Almost 5 years later, she relapsed systemically in January 2019. She had this reinduction, but became refractory. And then she was treated with Naxitamab GN-CSF through the trial and got a second complete remission in August 2020, very recently. So again, another example of what I meant all the time with event-free survival, meaning patients might be relapsing. This is no longer a surrogate marker of overall survival. This patient is doing excellent, doing well after 2 relapses, after relapse already. And this is what we can do for very refractory cases. We mentioned combinations, chemo and Naxitamab with GM-CSF. This is the irinotecan temozolomide or other chemotherapies combined with antibody that we have been using through compassionate use for the last 2 years. And this is a trial now that we just opened in our center called the NICE protocol, and the 203 trial, which will be opening in the next year through Wymb as well. Combination of anti-GD2 immunotherapy, Naxitamab GM, plus different combinations of chemotherapy, for now, irinotecan and temozolomide. This experience has been reported at the PSYOP meeting as well, and I'm showing you the combination of the HITs, the irinotecan temozolomide, plus the GM-CSF, and 4 doses of antibody through a 10 days backbone of GM-CSF and the irinotecan temozolomide given the first 5 days, as compared to the similar chemoimmunotherapy trial through the COG that has been reported. In total, we have treated in our center 55 patients of very refractory disease of prior antibody and prior chemotherapy, irinotecan temozolomide, which makes a major difference from the COG study. So patients that had received irinotecan temozolomide in the past, majority of our patients had received this combination of chemotherapy showing refractoriness were accepted in this trial. So in this study, so we have 48 patients available, and major responses, CRs and PR, were shown in 41% of the cases. Very significant responses shown for first time in the soft tissue compartment, as well as in the osteomedullary compartment that had shown refractoriness in the past. This is again another amazing example of this very refractory osteomedullary disease that had shown refractoriness to Naxitamab alone or irinotecan temozolomide alone, and with 2 cycles of the HITS combination, a patient became in complete remission. So after 2 cycles, we see most of the responses showing that in the setting of the relapse setting, 50% of the cases got into complete response as well. In conclusion, chemoimmunotherapy with the HITS combination has shown significant responses in this very refractory osteomedullary, but also soft tissue component disease. Responses were observed in patients that had already received, as I said, individual components, either the chemo or the antibody. The treatment is all outpatient again, and majority of our patients have shown the responses after 2 cycles, meaning we know very soon whether the patient is going to benefit out of this combination or not. We are currently testing other combinations of chemotherapy, ICE or cyclotopo, together with the same antibody, Naxitamab and antibody, Naxitamab and GM, to see whether these combinations also make a difference for these patients. So I said these patients, treated in this era of Naxitamab and antibody, anti-CD2 antibody effective treatments, are showing also recurrences, relapses, but those relapses are also quite amenable for the treatment because they are mostly isolated, even in the CNS, as Dr. Kramer has already mentioned to you. So why is that? Well, we are also suspecting the vaccination effect is what keeps these patients with an overall survival increase, meaning they don't die, despite the fact they still relapse in some isolated sites. And this is why event-free survival cannot be used anymore as a surrogate marker of overall survival in neuroblastoma. And this adaptive immune response, what is called the anti-idiotypic network, is what we believe those patients who are actually generating their own anti-idiotypic antibodies against CD2, those are the patients that are completely cured or partially protected. And those are the reason why they might be recurring, but not without the aggressiveness of what used to be in the past. So these patients generating their own anti-CD2 antibodies might be protected in the long term. And this is what has been seen in the vaccination strategies that I'm sure Dr. Modag will talk to you tomorrow, showing again this vaccination effect, protecting in the long-term patients for increased overall survival. So finally, my conclusion slide for all of you is that anti-CD2 immunotherapy should not be considered a passive, meaning it works while we are administering the antibody. we're actually looking forward to increase this vaccination effect. We need to learn more about this engagement of the immune system against the GD2 in order to make a cure beyond first-line therapy potentially more available for more patients. More potently designed antibodies and combinations can cure even more patients. Certainly, the combinations are now being tested worldwide by different groups. And I just don't want to finish just recognizing that parents have made the major changes in the discoveries of this disease. And Wymb is an extraordinary example of this once again. So my final acknowledgements to all my team, the staff at San Juan de Déu in Barcelona, who has engaged transforming the life of most high-risk neuroblastoma coming from worldwide to our center. Thanks for your time. Happy to take your questions.
Thank you, Dr. Mora, for the enlightening presentation. I'll jump straight to the questions by the order of popularity. So, what does extended access mean in a clinical trial? I see that Naxitamab, after complete response, is in extended access. What does it mean? Our oncologist can ask for it and get the medicine. Will it be available anywhere in the world or selected locations? Do we approach Wymb or the clinical trial for access? Would you be able to assist our oncologist in managing the side effects and dealing with them? Well,
extended access usually means that once the clinical trials are closed and Wymb has announced that the FDA is potentially going to be their final approvals of Naxitamab in the US by this month, November 2020. It means that clinical trials will be closing down in the US. So potentially patients might have access to the antibody through the Wymb company. And that's usually the meaning of clinical extended access. For the rest of the world, and that also might apply to some Latin American countries where the FDA approval might be automatically accepted in their own countries as an approval as well. For the rest of the world, we have to continue on the trials, and that's what we are now doing, expanding the multi-institutional opening of the 201 trial in Europe in order to make collect the data in order to the EMA for the approvals, etc. So in the US and Latin American countries, extended access might be useful for some time through the Wymb company. For the rest of the world, we need to keep on accruing patients in the trials in order to get the final approvals.
Thank you. The next question is, how does a child qualify for compassionate use programs? Are they available in Barcelona or at other Wymb centers?
Well, as far as I know, the compassionate use program is only available in our center for the last 3 years. We were the very first center to administer Naxitamab in the world, and the experience that we have acquired has made the Wymb to build a trust with our group. So I'm just extremely happy that we can provide this antibody to most patients coming to our center from everywhere.
Thank you. The next question is, a number of patients treated with Naxitamab in frontline therapy go on to receive further maintenance therapy with the MSKCC bivalent vaccine. How is this accounted for the interpretation of the final results? How do you determine if improved survival rates are due to Naxitamab as opposed to the combination of the two therapies, or if the maintenance even is DFMO in some cases?
Well, it's a good question. Of course, antibodies have already shown to improve overall survival of these patients before any of these further strategies were available. So this is no longer a question. We know that anti-GD2 antibodies improve the overall survival of these patients. What is not yet proven is whether vaccine increases the survival of these patients. It's still in trial. It needs to be tested, as well as the FMO. So both of them are very good strategies that are currently being tested, but yet have not shown to improve the survival of patients formally.
When will we see MSK vaccine available in Europe, Barcelona?
Well, we are working with Wymb to make this strategy also available outside of the US very soon. So the availability is still not, so the timelines are still not quite clear, but we are hoping first quarter of 2021, the trial will open certainly outside of the US in hopefully many centers.
Thank you. For relapsed patients, is there a benefit to having both dinutuximab and naxitamab to make sure that child has best chance of achieving and staying in remission? Are they different enough so that it makes sense?
Well, both antibodies are anti-GD2, so meaning they have the same target. So it will not make much sense to use them both at the same time. We have used Naxitamab for patients relapsing after dinutuximab being effective. I'm not aware of the vice versa, but most families and patients worldwide have no access to any of those antibodies. So having access to any of them will make a difference in that setting. So I'm encouraging everyone to, families or patients to make all the efforts possible to get to complete remission mainly, and then go for any place where they could have the benefits of any of the anti-GD2 antibodies.
Any experience from combinational use of anti-GD2 with any other inhibitor, namely PD-1, nivolumab? There are papers that have shown anti-tumor activity in difficult cases.
Well, we have no experience at all, and we are actually working on a subgroup of cases where there is stable disease while on treatment, meaning those persistent sites remain despite the chemoimmunotherapy, for instance. We are actually biopsying those sites and looking for what is going on there in order to understand what else we can add or change in order to make those antibodies more efficacious, but yet still on the research arena.
I understand that MSK bispecific treatment didn't work well despite getting to a fairly high dose. What are the next steps?
Well, I didn't talk about vaccine. Hopeful that Dr. Modak tomorrow can show all their experience that is yet unique at MSK, so I cannot comment on that.
How manageable is the pain related with naxitamab?
Well, this is a good question because the reactions of naxitamab as compared to the dinutuximab are quite different. They are much more intense, but also much shorter in time. While the infusion is over, the patients do recover and they all go home. So the pain reaction is really certainly very intense, but most of them, 2/3 of them, can be managed with classical opioid-based regimens that were used also from the dinutuximab era. In our group, we have also shown that for those a quarter of patients that are unmanageable with classical regimen, we have devised a non-opioid-based mechanism of treatment, which is based on ketamine with the help of anesthesiologists in the procedure room. And we've been able to rescue majority of those patients in order to make them get through the whole treatment. So there are strategies available now that can ensure the majority of the patients can undergo proper treatment.
We are right on time, so I think we'll take maybe a couple more questions and then we'll finish. Please clarify, have you found hu3F8 more effective against relapse than dinutuximab?
Well, in our experience, which is very limited, we had treated in the past 24 patients with the COG strategy, meaning dinutuximab, Unituxin, plus GM and interleukin-2. And we had the luxury also of treating 12 of those patients with bone and bone marrow refractory disease, which was at the time quite unheard of. In our own experience, we never achieved a complete remission using that strategy. Whereas for Naxitamab, now I showed you about 70% of our patients with osteomedullary disease achieving complete remission. So in this limited experience, we can certainly say that Naxitamab is much more potent against osteomedullary refractory disease.
Can Dr. Mora give his opinion on what happens if a patient doesn't clear all the disease after treatment with beta-D in frontline therapy? At which point would Naxitamab be considered?
Well, as I showed you, there are several strategies after induction. If patient does not get into complete remission, if the persisting disease, refractory disease, it remains within the bone and bone marrow compartment, that's the 201 trial I showed, with 70% of our patients getting into complete remission with only antibody, and then they can move on to other strategies. So that's for the refractory disease in the bone marrow compartment. For patients refractory in the soft tissue compartment, we always need to consider further radiation, further surgery. But if that's not no longer available, then we can use strategies like the chemoimmunotherapy, as I showed you, with 40% of those patients actually getting into complete remission. So in both settings, we have very good chances of getting those patients into complete remission, which was actually impossible in the past with conventional treatments.
Thank you very much, Dr. Mora, for addressing the questions. Thanks everyone for asking them. This is the last session of the research and clinical track for today. It will continue 9 a.m. London time tomorrow. The aftercare, the importance of aftercare and long-term follow-up on the supporting care and special interest track is still going on in case you'd like to hop over.